Yes, sir. Good evening, respected Professor Sir and dear students. I welcome you all to today's session of RAISA DNB online academic activities. First of all, I invite Dr. Bindu to present the topics on Ramsay sedation score and physiological changes at high altitude. Over to Professor and students. Thank you.
You can go
Good
ahead.
evening.
Good evening.
Yes, sir. My first topic is Ramsay sedation score. It's a 6-point scale used to measure and monitor the depth of patient sedation. It is based on patient's level of consciousness and response to stimuli. If the patient is awake, the level of agitation and cooperation is evaluated and scored accordingly. If asleep, non-painful stimulus like level or tap or loud voice is used to test the responsiveness. It includes 6 scores. Score 1 is the patient is anxious, agitated, restless. Score 2, cooperative, oriented, and tranquil. Score 3, patient is responsive to oral commands only. Score 4, the patient is asleep, brisk response to glabell or tap or a loud auditory stimulus. Score 5, patient is asleep, has sluggish response to glabell or tap and loud voice. Score 6, patient is asleep and there is no response to painful stimuli. The usefulness includes it helps in monitoring sedation to adjust and titrate the sedatives and maintaining appropriate level of sedation. It prevents over sedation and under sedation. It is very simple and can be easily used by the caregivers. The limitation is it do not provide a clear tune measurement of agitation like other scales, which includes Richmond Agitation Sedation Score, cannot be assessed in paralyzed patient with neuromuscular blockade and cannot be used relatively can't be used in deaf people. Thank you, sir.
Was this first introduced to assess the sedation in ICU?
Sir, couldn't get you, sir.
Was this Ramsay 4, was it introduced in ICU or elsewhere?
ICU, sir.
Huh?
In ICU only, sir.
It was not initially meant for ICU sedation assessment. Okay? It was
Okay.
introduced wherever patients were operated under regional techniques, like your spinal epidural or your nerve blocks. Then the patient did not want to be awake or afraid of being awake when the surgery is going on in that part of his body. They introduced the sedation to keep the patient calm and anxiety free. So at the time when they gave the sedative drugs, some of them became very drowsy and too deeply sedated. Okay, so to assess the depth of sleepiness or sedation and the wakefulness, both they wanted to assess. So that is the first introduction of this Ramsay score only for the operating room when patients were getting operated under regional techniques. Okay? But later on, when patients required sedation for mechanical ventilator and other procedural issues in intensive care unit, they utilized the same scale there. So it was also adapted to ICU scoring for either maintaining the patient on sedation or when they want to wean the patient from the mechanical ventilation. You also need to de-escalate the sedation, make the patient more conscious and alert so that you can see whether he can tolerate being disconnected from the ventilator and breathe on his own. So for that purpose also they extrapolated the same scale to ICU usage. Okay, so that is how the Ramsay scale was the history evaluation or evolution happened like that. So initially it was in the OT for regional cases when the patient required sedation. The scale was used. Later on, the scale got more impact in the ICU setting or critical care setting where patients were sedated and of the sedation. For both the purposes, they started using this. Okay, right. So that is a very small topic only. So
Yes.
however you write, you can introduce this point in your answer as the first introduction. Okay. It was not meant for ICU sedation. It was meant
Yes.
initially for
Region.
OT sedation for regional technique cases. Then it was utilized for ICU sedation. Okay. What is the next topic in your question?
Physiological changes in high altitude, sir.
Physiological changes.
Shall I
You
start?
can go ahead. Yeah.
Yes, sir. So altitude above 3000 meters is considered high altitude. As altitude increases, barometric pressure decreases in a non-linear fashion. The relative concentration of gases remain constant, but the partial pressure of the gases decreases. The temperature falls every 1000 feet. That would be 2 degrees Celsius fall. As barometric pressure falls, there is a hypoxia, which leads to hypoxia at the tissue level also. The cardiovascular changes include on exposure to hypoxia, peripheral chemoreceptor will be stimulated. There will be increased sympathetic activation. There will be increased heart rate and increased cardiac output. Systemic vasodilation happens on ascent, but antagonized by the increased sympathetic tone. Hence, the BP is increased. After several days, cardiac output becomes normal with low stroke volume and increased heart rate, and BP used to be high. Maximal oxygen consumption is decreased on increasing altitude, that is 1% decrease 100 meters above 1500 meters. Hematological changes, the hemoglobin concentration is increased due to increase in altitude as the plasma volume will be decreased. There will be increase in erythropoietin, hence there will be increase in RBC production. The hemoglobin concentration will be increased, which helps to increase the oxygen arterial content. So arterial oxygen content. There will be increased oxygen delivery to the tissues. The marked increase in hematocrit and increase in plasma viscosity is seen. There will be 38% viscosity increase over 5,800 meters. The respiratory system, as the barometric pressure decreases, the partial pressure of oxygen is decreased, and there will be increased alveolar and to increase the alveolar and arterial oxygenation, there will be hypoxic ventilatory response. The decrease in PaCO2 stimulates the peripheral arterial chemoreceptor. It results in increase in minute ventilation, and there would be decrease in PaCO2, that is hyperventilation, which leads to decrease in carbon dioxide PaCO2, which helps in increasing partial pressure, arterial oxygen content as by alveolar gas equation. Due to hypocapnia, there will be left side shift of ODC curve, which results in improved oxygen uptake by the lungs. The increase in O2 affinity is increased, oxygen affinity is increased, and the leftward shift of ODC curve helps in adaptive response for the hypoxia. The increase in PaCO2 results in respiratory alkalosis, which is corrected by the excretion of bicarbonate by kidneys in the later days. Decrease in PaCO2 causes hypoxic pulmonary vasoconstriction in seconds to minutes. There will be increase in pulmonary vascular resistance by 50 to 300%. The pulmonary arterial pressure is rise, and it can result in high altitude pulmonary edema as a altitude illness. Renal and endocrine changes include hypoxic diuretic response, which is mainly due to hypoxia and hypocapnia. There will be natriuresis and diuresis, can be due to reduce in renin-angiotensin aldosterone production, and cortisol level is increased in high altitude. Coming to the central nervous system, there will be sleep disturbance in 65% people, and the stage 1, stage 2 sleep is increased. Stage 3, stage 4 deep sleep duration is decreased. There will be frequent awakenings, and periodic breathing is also identified in these patients. There will be hyperapnea followed by apnea. This is mainly due to a hypoxic ventilatory response. Coming to the cognitive function, the arithmetic, memory, language, and motor skills are decreased in these patients. there would be a new onset anxiety disorder. Coming to the gastrointestinal system, anorexia is frequently observed. It is due to increase in leptin as well as increase in cholecystokinin. It is both are satiety hormone. They may also lead to acute mountain sickness. It is a most common acute altitude pathology occurring on more than 2,500 meters altitude. It's seen between 4 to 12 hours. The main causes hypoxia and hypoxemia lead to increased cerebral blood pressure, and there would be increased blood-brain barrier permeability leading to cerebral edema as well as increased intracranial pressure. The clinical features would be headache, nausea, anorexia, dizziness, sleep disturbance, and fatigue. Lake Lewis score is used to identify the cognitive as well as gastrointestinal disorder of these patients. Treatment is pre-acclimatization, avoidance of exercise, adequate hydration, oxygen supplementation. Acetozolamide can be used as a adult dose 150 mg twice daily. Dexamethasone can also be used. High altitude cerebral edema is a severe life-threatening disorder. It has a cerebral edema associated with microhemorrhages, primarily in the corpus callosum. Clinical features mainly include ataxia, confusion, psychiatric changes, altered sensorium, coma, and death. High altitude pulmonary edema, it's a non-cardiogenic pulmonary edema occurring more than 2,500 meters. It's seen between 2 to 5 days of ascent. It's uncommon after 1 week. Risk factors mainly include male sex, respiratory infection, cold temperature. Pathology is mainly due to increased hypoxic pulmonary vasoconstriction leading to increased pulmonary artery pressure. The bioavailability of nitrous oxide is also low. Nitric oxide is also low, hence leading to the increased pulmonary artery pressure. The clinical features mainly include exertional dyspnea with dry cough. There would be decreased excessive intolerance. It may also lead to progressive dyspnea along with pink frothy sputum. On examination, the respiratory rate will be increased, heart rate will be increased, cyanosis, crepitation can also be found. On ABG, there will be profound hypoxia. The treatment would be gradual ascent. Nifedipine can be used in high-risk groups. Salmeterol, tadalafil can be used. Supplemental oxygen and hyperbaric chambers are used. Dexamethasone and PDE phosphodiesterase inhibitors as a low importance. Chronic mountain sickness is also known as Monge's disease. Clinical features include excessive erythrocytosis. It's mainly due to chronic hypoxia and central hypoventilation, leading to pulmonary hypertension and other complications like congestive cardiac failure, carpulmonale. The excessive erythrocytosis is considered when the hemoglobin concentration is more than 19 grams per deciliter in females and more than 21 grams deciliter in males. Clinical feature is mainly headache, dyspnea, fatigue, sleep disturbances, burning sensation of hands and feet, cyanosis, finger clubbing, etc. The gold standard score used is Wing High score. Thank you, sir.
So is there a decrease in the percentage of oxygen in the atmospheric air at high altitude?
No,
You
sir.
said hypoxia happens.
Yes.
What is the cause of hypoxia?
The partial of oxygen is decreased in the altitude, sir.
Okay. So do these changes what you described like pulmonary edema, cerebral edema, all those things occur in everybody at all levels of height above the sea level?
No, sir. It depends on the patients, the way the patient adaptations, sir, and the altitude also, sir.
So the physiological changes, you have to first classify them as acute changes and chronic changes. Okay. So those who do not have, for example, a COPD patient or an asthmatic patient goes to altitude of than 5,000 meters, will they be able to survive there without any difficulty?
No, sir.
What will happen to them?
They need a O2 supplementation for them.
Their acclimatization will be very poor. Okay, they cannot adapt themselves to that high standard, high levels are high, where the barometric pressure is very low. So they inhale the oxygen, alveolar oxygen. You have to talk that terminology should come. What will be the alveolar oxygen level at high altitude? What are the factors affecting the alveolar oxygen? What is the alveolar equation? How do you calculate the alveolar oxygen content by equation?
So it's a partial pressure of oxygen subtracted by partial pressure of carbon dioxide divided by respiratory quotient. Sir.
Respiratory quotient. Okay, so that formula has to be included in your answer. To
Okay.
see how they become hypoxic. Okay, and the Monge's disease is a pathological process. It is not a physiological change that happens. So you may not include that in your answer.
Okay. Sir.
But otherwise, all the points that you have given are quite okay. I'll just share my screen.